discussing about serum uric acid estimation. Okay, so uric acid estimation, why we do it? Uric acid, one of the nitrogen substance, waste product, and produced in liver due to purine metabolism or nucleoprotein or nucleic acid metabolism. Adenine and guanine, from that uric acid will be formed from adenine and guanine, and due to metabolism of purine, nucleoprotein and nucleic acid. Now in clinical settings, what you see? Gout. That is, normally you see big toe, distal joint, there is red color, swelling and painful joint movement. So what happens? There is sodium urate crystal deposition into the synovium, causing synovial irritation, inflammation, and all that feature will arise. Why it happens? Decreased pH, cooler temperature, during sleep, less movement, all that will precipitate that uric acid crystal formation into the joint and causing inflammation. So, and increased uric acid in blood is called hyperuricemia, and if it's excreted through urine, it is called uricose-uria. In blood is hyperuricemia, and in urine, if it's excreted, it is called uricose-uria. Normally what happens, uric acid is absorbed in proximal convoluted tubule, and so any problem in proximal convoluted tubule disease like Fanconi syndrome, there will be proximal convoluted tubule defect. So there amino acid, glucose, phosphate and this uric acid will not be absorbed. So that time it can be excreted. Other than Fanconi syndrome, you have Polycythemia vera. These three lineage of blood, peripheral blood, WBC, RBC and platelet would be increased. So there is increased production and increased destruction. So uric acid will be more. Polycythemia vera will cause increased uric acid. Hypothyroidism. Thyroid hormone will help heart to contract. So heart is not contracting more means the blood flow to the urine is, to the kidney is less. So the filtration rate will be, renal plasma flow will be decreased, decreased renal plasma flow, decreased GFR. So that time uric acid will be increased in body. So hypothyroidism will cause increased uric acid. Peripheral blood cell. WBC, RBC and platelet, all the lineage will be increased in Polycythemia vera. Polycythemia vera is JAK2 mutation, panmyelosis, and hematocrit will be more than 49% in male and 48% for female. Hematocrit, its packed cell volume, all that will be more. Hematocrit will be more. Huh? So kidney, if its kidney is not perfused properly, so it is not going to excrete it properly. So it is increased in blood. Renal plasma flow. In Wilson disease, what happens? Copper toxicity is there. Copper will destroy the proximal convoluted tubule. So uric acid will not be absorbed. So uric acid will be excreted. So that time also uric acid will be low. For the Wilson's disease, uric acid will be low. Okay, Wilson's disease, copper toxicity, and there will be destruction of the tubular cell. So that time for Wilson's disease, you will therapy is D-penicillamine or zinc. You will give. Two to 5 milligram per dl for female, 3 to 7 milligram for male, and this is the uric acid level normal, and for female more than 6 and for the male more than 7 milligram per dl. Uric acid presence in blood will cause hyperuricemia. Leukemia also will be increased uric acid because of rapid cell destruction. Tumor lysis syndrome. Leukemia, there will be increased production of WBC, all that, and so there will be increased destruction also. Increased production and increased destruction will cause increased uric acid. Which type of leukemia you have to say? And progressive renal insufficiency, if it's there, then also will be increased uric acid. Anywhere renal perfusion is not properly happening, that time also uric acid will be more. Polycythemia vera, if you have to remember, if you can remember some of the points, there will be JAK2 mutation, panmyelosis, and there can be itchy skin, and diagnosis normally after 60 years of age, and treatment is phlebotomy and aspirin. All the three lineage, WBC, RBC and platelet production will be more. Panmyelosis. JAK2 mutation. Panmyelosis, and there will be JAK2 mutation. Janus kinase, JAK2. Diabetes mellitus, there will be increased insulin and decreased kidney damage will be there, and there will be retention of uric acid also. In diabetes also you can see the increased uric acid, because renal will be perfusion, renal destruction will be there, diabetic nephropathy. In that you can see that filtration will be not be properly done, so that time also uric acid will be increased into the body. Diabetes mellitus. And atherosclerosis also, uric acid is important. Uric acid decrease nitric oxide synthesis, so relaxation of the blood vessel will not be happening, so blood vessel will be stiffened, so that endothelial injury will be more. If its endothelial injury is more, so atherosclerosis formation also will be more. So uric acid, increased uric acid cause atherosclerosis or hyperuricemia observed in atherosclerosis. So hyperuricemia may be observed in renal dysfunction, gout, leukemia, polycythemia, atherosclerosis, diabetes and hypothyroidism. All the causes are described. And decreased level are present in Wilson's disease. In Fanconi syndrome, there will be generalized tubular dysfunction. So glucose, amino acid, phosphate and uric acid will not be absorbed. What you can remember? One is diabetes. In atherosclerosis, it is nitric oxide is not forming properly, so that time stiffened blood vessel and causing endothelial injury more. So other than that, it has free radical formation also. Uric acid may help in free radical formation. See, all the explanation I didn't get from book. Okay, some of the explanation I have seen from the net also, because I have known the clinical importance and clinical scenario where uric acid is more. But from the textbook, if I have to go through, I have to check little bit more. This is from textbook as well as from net. If anywhere any change is there, I'll inform later. Okay. So what all the hyperuricemia happening in renal dysfunction. Renal dysfunction, when renal is not perfused properly or renal flow is less, so that time, and gout, leukemia, polycythemia, atherosclerosis, diabetes, hypothyroidism. Renal insufficiency is also one of the cause, and gout, leukemia. This is the hyperuricemia, and decreased hypo is decreased uric acid is Wilson's disease. Copper toxicity causing tubular damage. So it is not absorbed and released, extruded from body. Now we will read about the method. Allantoin. Uric acid, with the help of uricase, it will form allantoin and H2O2 and carbon dioxide, and H2O2 with the help of 4-aminophenazone and 2,4-dichlorophene sulfonate, yeah, 2,4-dichlorophene sulfonate. It will form with the help of POD, quinoneimine and water. Quinoneimine is red color, so the reaction will be reddish. Reddish color will be red in color. Quinoneimine. Quinoneimine. So the principle is uric acid is oxidized by uricase to allantoin and hydrogen peroxide. Can you please not speak much? Uric acid is oxidized by uricase to allantoin and hydrogen peroxide when under the influence of POD, that is peroxidase, 4-aminophenazone and 2,4-dichlorophene sulfonate forms a red quinoneimine complex, and intensity of the color will be proportional to the concentration of uric acid into the sample. Sample is plasma, blood, plasma, serum or urine. So what? Everywhere in the method you will write this thing. The intensity is of the color is proportional to the concentration of the whatever the solute or the enzyme concentration of that into the sample. This line you have to write there, because looking at the color only you can tell that concentration is more or less. What? 2,4-dichlorophene sulfonate. 4-AP is 4-aminophenazone and DCPS is 2,4-dichlorophene sulfonate. Okay. Anything else? No. Okay, fine. Got it? So this is the reaction and method. Method is Uricase and POD method, peroxidase method. This is just know it, don't have to write. I think uricase is used, POD peroxidase is used, and in liquid medium. So there is something R1, R2, R1 is buffer reagent, that will be phosphate buffer, and DCPS 2,4-dichlorophenols sulfonate, and for R2 it will be enzyme, that is uricase, peroxidase, ascorbate oxidase, and 4-aminophenazone, and calibrator for the standard it will be 6 milligram per dl. Standard is uric acid aqueous primary standard, so it is aqueous form. Uric acid standard is 6 milligram per dl. Fine. R1 is buffer, R2 is enzyme. In buffer phosphate DCPS is present, in R2 enzyme is 4-aminophenazone, ascorbic oxidase, peroxidase, and uricase will be present. Okay. Working reagent will be 500 and 500 microliter from R1 and 500 microliter from R2. So equal volume will make 1000 microliter. WR is working reagent. It is R1 plus R2 500 plus 500 microliter together will form 1000 microliter, and B for blank, S for standard, T for test, and 25 microliter for blank. Standard will take standard solution of 25 microliter and test solution will take 25 microliter. The color will be red, and the thing is we have to incubate. If it's 37 degrees centigrade, it's 5 minutes. If it's 15 degree to 25 degree centigrade, 25 degree also you can say. So, if it's room temperature, it is 10 minutes. If it's in water bath, 37 degree centigrade, it's for 5 minutes. So, you will calculate. Then this is a procedure. Now, you will be doing the calculation. That is the calculation. B stands for blank, A stands for standard, T stands for test. Huh? This is the calculation, absorbance of test. At the end of incubation, you will take the test sample. What is the absorbance? Sorry. Yeah, actually blank. This is also same. Actually, what happens? This is the 3 test tube we are taking. If I don't write this one, this is the correct order. 1000, 1000, 1000 distilled water, and this is the sample, this is the test. And I am telling this is we are taking the blank, this is we are taking the sample, this is we are taking the test. Where problem? The now reference value for this kit, Omen is 2.5 to 6.8. Actually, Vasudevan 2.2 to 5 and 3 to 7 it's given. So, previous one did you write? 2 to 5 and it's given in Vasudevan, you can go and check. You got I think 2 to 5 milligram for female and 3 to 7 for male. And here in the kit it is given So this is the reference value given in the kit, 2.5 to 6.8 milligram per dl for female and 3.6 to 7.7 milligram per dl for male. And urine, it is 250 to 750 milligram per 24 hours. Actually in Vasudevan it is written 500 to 700 milligram per 24 hours. 500 to 700 milligram for 24 hours. Uric acid excretion also fairly constant, about 500 to 700 milligram per day. Kite. Uric acid, huh? Na urine, the whole 24 hours average, 250 to 750 average in urine for both. This is in Vasudevan and this is in this kit. Urine is separate kore bola nai. And you will measure at 520 nanometer. This filter is also fine, 520 or 490 to 550 nanometer. Interference, bilirubin, hemoglobin and ascorbic acid. Bilirubin, hemoglobin and ascorbic acid will interfere. There is some of the value is there. Bilirubin up to 170 micromole per liter, hemoglobin up to 130 milligram per dl and ascorbic acid up to 570 micromole per liter. But if you can't remember all the value, you can write bilirubin, hemoglobin and ascorbic acid will interfere. If you give the value, it will be better actually. Bilirubin 170 micromole per liter, hemoglobin 130 milligram per dl and ascorbic acid 570 micromole per liter will interfere with the result. When you are checking, you have to see the reagent is not particle, in the reagent there is no particle or turbidity is not formed, and the light path is also 1 centimeter, here also, and the color is stable for 30 minutes. The quinoneimine dye, whatever was formed, that color will be stable for 30 minutes. So within 30 minutes better you finish the result. One thing, Polycythemia vera I had told, okay, you write Polycythemia, not Polycythemia vera. I have to check it more, like there is any difference in that. Whatever I told about Polycythemia vera, and you will write in this only Polycythemia. So uric acid, increased uric acid, you will write Polycythemia. Okay, not Polycythemia vera. I had to double check it actually. And I had told about Polycythemia vera. Exercise can increase, slight increase of in uric acid. Exercise can slightly increase uric acid. Creatine, uric acid and creatine kinase. Also lactate dehydrogenase, AST, aldolase, all that. So creatinine, uric acid and creatine kinase slightly increased. Deficiency, Lesch-Nyhan syndrome. Okay, some of the disorder of purine metabolism you write gout. Left side you write gout. Second line you write Lesch-Nyhan syndrome. Third line immunodeficiency, left side. Fourth line Xanthinuria. And subacute combined immunodeficiency, that is SCID. Subacute combined immunodeficiency. Some of the disorder of purine metabolism is gout, Lesch-Nyhan syndrome, immunodeficiency, Xanthinuria and subacute combined immunodeficiency. Yeah, I'll tell. Just remember the name. When you go through the topic discussion, you will know better. In gout, there will be defect in phosphoribosyl pyrophosphate PRPP synthetase, HGPRT. HGPRT stands for hypoxanthine guanine phosphoribosyl transferase and glucose 6-phosphatase. Three things defect will cause gout. So gout, there will be phosphoribosyl pyrophosphate synthetase deficiency, HGPRT deficiency and glucose 6-phosphatase deficiency. HGPRT, hypoxanthine guanine phosphoribosyl transferase. Lesch-Nyhan syndrome, there will be HGPRT deficiency. Here one peculiar character is there, self-mutilating feature. A person will harm own self, and that is the deficiency of AGPRT. Immunodeficiency, purine nucleotide phosphorylase deficiency. Purine nucleotide phosphorylase deficiency. Xanthinuria, xanthin oxidase. Xanthin oxidase deficiency. And subacute combined immunodeficiency is adenosine deaminase. Subacute combined immunodeficiency, adenosine deaminase is mostly present in lymphocyte. So, in the deficiency of this adenosine deaminase, lymphocytes will be very much reduced, and there is both T and B cell lineage will be affected, and immunodeficiency will be seen. For the gout, we can give Probenecid. This is uricose-uric drug. So, reabsorption will not be happening and uric acid will be excreted through kidney. So, uricose-uric drug is Probenecid. Other than that, we can use NSAID. And corticosteroid also in the last stage, if it's not decreases in inflammation and pain, patient is suffering much, you will use corticosteroid also. Another one is allopurinol. First drug we will give allopurinol, then Probenecid and all that. Allopurinol first drug I don't want to say. You will prescribe allopurinol, along with it you can prescribe Probenecid and NSAID, colchicine and corticosteroid. Colchicine. Allopurinol will block formation of uric acid. Okay, some of the gout attack location, if you know. First two affected in 90% of individual with gout. First two affected in 90% of individuals with gout. Okay, other than that, knee, ankle and in between here also, midpoint, okay, of the foot. There also midpoint, I don't want to say, mid section of the foot. In the foot there also will be gout manifestation will be there, and other than that, elbow can be one of the site, and less common will be here, shoulder joint, the finger and here. See the picture in figure in Vasudevan, and study. So 90% case toe, first toe, and other than that this elbow, foot, and ankle, knee. These things you remember.